Good afternoon, everybody. Thanks for joining again. And I don't know which view you're seeing. We're having our webinar this afternoon is debunking COVID-19 myths. And I'm gonna just make sure you're seeing the right screen because I have a feeling you're not. Yeah, you're not. Okay. Let me share my other one. Alrighty, so I have just shared my screen with everyone just so you have an idea of what we're doing today. So thanks for joining, and we are going to have our presenter speak in a couple of minutes. I'll just do a quick intro, if you don't mind. And again, welcome from the board. I think we've done this a couple of times now. I'm Sue Jones, your president, and Kelly Hassel has kindly arranged for Dr. Zain Chagla to join us and provide some information around COVID-19 today. We have our director and editor-in-chief of RTSO Airways, Shauna McDonald, our treasurer, Sue Martin, Wendy Foote, Sylvia Mortimer, Farzad Rafi, and Gino DePinto, all directors with specific kind of pieces of work they do for the board as well. And our non-voting members include Nancy Garvey, Mika Nonioma, Steve Buziak, Tina Yan, Shirley Quach, and Greg Dondy. And again, everybody has a bit of a role within the organization on certain groups. So what I wanted to do was talk a little bit about everyone's ability to come together to work on, to care for our patients in terms of COVID-19. We got some really good news yesterday from the province and the projection models, which was a great piece of information to hear, but there's still lots of patients out there who are positive, who are on ventilators, who still require our care. And I just want to say a big thanks to all of you for doing what you're doing and continue to do that work, as it's extremely important. And however we can support you as an organization, please feel free to email us if you have ideas about webinars or other topics as well. So I'll just quickly introduce Dr. Chagla. We want to get right into this because we want to leave some time for questions afterwards, because I'm sure you're going to have lots of questions. So Dr. Chagla is an associate professor of medicine at McMaster University, is an infectious disease consultant at St. Joe's Healthcare in Hamilton. He's also the co-medical director of infection control at St. Joe's in Hamilton, as well as Niagara Health System. He's also a part-time consultant to Woodstock General Hospital. As part of the provincial response, he's also been part of Ontario Health Guidelines on personal protective equipment, as well as treatment of COVID-19. So in saying that, I will turn it over to Dr. Chagla. I'm just gonna give him presenter mode, and off you go. Thanks.
All right, so let me see if that displays properly. It looks like it's displaying properly. Okay. Good afternoon, everyone. Thanks for having me. I'm happy to present here, and I think obviously a lot of new stuff going on around COVID-19 and some good news that's coming out. And when given the opportunity, I was happy to present, just because you guys are a core group of people that are very intimately involved in COVID-19, and so I'm happy to go through this. I have about 30 slides or 38 slides. Some of them are very quick, and that should leave a good 20 minutes or so for questions, which is usually what these sessions come into, and I'm happy to answer as much as I can. All right, so the one thing outside of medicine that I'm hugely passionate about is the Toronto Raptors. I gave a talk, it was probably about 4 weeks ago, about COVID-19 to the medical staff at McMaster. And at that time, the global case count was about 19,000 or 20,000 that day. It's just incredible, as I was looking through those slides again to help populate this slide deck. looking at the numbers, we're way over 2 million. So, we're talking 100 times the stadium. And just the global deaths are starting to approach what this stadium would fill up. And so it's just a remarkable time in history. It's also something to reflect on, for what we do for our patients and what we've done for our patients. This has unfortunately been the human consequence of everything, and at the end of this, we'll recognize all these people that lost their lives because of COVID-19. The only other thing I have a big passion about, obviously, is my little daughter here, who's screaming in the background. Hopefully, you don't hear her during this presentation. But she's 9 months old. She was about 5 months old at the time this pandemic hit, or at least was starting to be described. I am constantly shocked at what she's been able to do in the last few months and all the progress she's made. But it's just a reminder of how young this outbreak is, how very much the data and the stuff that we rely on for management is really, really, really in its beginning phases, and how we're just learning day by day and going day by day with it. So just to go through it, and I think one of the quotes from Osler I use quite a bit for this, just because there is a lot of there's a lot of inattention to detail and a lot of inattention to the evidence. Osler said, and Osler is one of the most famous Canadian physicians of his time, it is astonishing with how little reading a doctor can practice medicine, but it is not astonishing on how badly he may do it. And just a good example in terms of not only the information, but the misinformation out there, and really having to sort through it all as part of this pandemic response. So today we're going to go through a number of different things. Now, one is COVID-19 epidemiology, and I know there's actually a handout for the Ontario modeling data, and I'll present some of it too as well, because I think it's important as a definite optimism for the group moving forward. I think the meat of this presentation is really going to go through Airborne versus Droplet and infection control and PPE, because I presume that, and from the questions, this is probably the biggest clinical concern. And so we'll go through a bit of the pathophysiology around it and what makes this unique, or what makes this not unique as compared to prior infections. We'll talk a little bit about the diagnostic testing, microbiology, and clinical characteristics of patients, and touch briefly upon asymptomatic carriage. And then a bit on treatment in future directions, but obviously I want to open it up at the end of this for everyone in terms of answering and responding to questions. Just to reemphasize how fast this has changed, and I remember reading this email on December 31st. There's a list server called ProMed, which is a bunch of ID stuff that's given to different professionals around the world, that anyone can sign up for. And I saw some note of a cluster of cases of pneumonia of concern. These things show up from time to time on these email chains, but within the next couple of weeks, it was very clear that there was something different here, and it was a novel coronavirus. And we saw the world essentially change because of it, and continue to change because of it to something that hasn't been seen before. Briefly, coronaviruses are positive sense RNA viruses, so they have the genome kind of within, and that can make proteins. The RNA is replicated, and then that's used as a template to make proteins and virus particles. It is surrounded by an envelope of fatty acids, which make it very difficult to survive in the outside environment. We'll talk a little bit about the environmental controls, though. It's typically carried by bats, and bats are the reservoirs of coronaviruses. We're not really sure where the human to animal interface came, though. It probably was not a bat, but there's some question of whether or not it was some of the fresh livestock at the Wuhan supermarket that led to this. There are multiple other coronaviruses that do circulate from time to time. For those of you who work in hospitals that do those nasopharyngeal swab samples of people during cold and flu season that list off a bunch of different viruses. The 4 or 5 human coronaviruses are part of this panel. They cause cold-like symptoms that rarely are associated with significant disease. But there's been 2 prior epidemic types that have been described in history. One is the severe acute respiratory syndrome we saw in 2002, 2003. And the other is the Middle Eastern respiratory syndrome, which is still a somewhat threat in the Middle East around the Riyadh region of Saudi Arabia, but has had cases outside in that sense. And these are more epidemic spread, although their ecologies are a little bit different person to person. The SARS virus is very similar to this coronavirus, whereas MERS is more of a distant cousin. And the spread, and we'll go through the infection control in a little bit, is really that droplet contact transmission. Again, we'll expand on that later in the presentation, as that's a point we want to go over quite a bit. So looking at the global ecology, this is just the last 7 days from the World Health Organization. So you see the hotspots in the world, the United States of America, unfortunately, and particularly New York, as we'll highlight. You see the Middle East, particularly Turkey and Iran, Europe, all throughout Western Europe. Russia is now entering an outbreak, which is fairly new. Brazil and Mexico are now entering outbreaks too as well. And lack of cases in sub-Saharan Africa, and it's not very clear what the issue is. Is it under testing? Is it something specific to that population, particularly a very young population, which is at lower risk of respiratory infections? It's very unclear what the data is, but all countries other than really those in North Africa and South Africa itself have reported very few cases. This is the US map, which is much more worrisome. So you can see the US is a lot of different outbreaks all at once. It's really hard to be heterogeneous about this or homogeneous about this. You see the epicenter as the New Jersey, New York area, where there's been greater than, in that region, greater than 320,000 cases and a significant number of deaths. You see as well Chicago and Michigan, so kind of our border states, also being affected, and then the West Coast and Florida being the other 2 major hotspots in the United States, and then localized infections or localized outbreaks in other states across the United States. This is Canada's most recent situation as of yesterday. I haven't uploaded the numbers today. We see about 11,000 cases in Ontario, 19,000 cases in Quebec. The big caveat to this is every province's testing requirements are very different. So in Ontario, we've adopted a strategy similar to British Columbia and Alberta to test people at highest risk, test healthcare workers, test people from vulnerable settings, and test patients in the hospital. Whereas Quebec has been much more on board with testing everyone and testing everyone aggressively who has symptoms. And so it's no wonder that their case counts are a little bit higher because you're looking more. But death rates and hospitalizations are actually a little bit better per capita than Ontario. So that may skew the data in terms of total cases. This is Ontario's latest data as of yesterday or the day before. So you see the number of cases. You do see 10% distribution in healthcare workers. It's important to note, though, those aren't reflective really of healthcare workers being higher risk. There is probably a little bit extra risk, obviously, from being exposed to COVID patients. The other part is they're the only real community group that's being tested outside of some of those other indications. And so they're much more likely to be represented in these types of studies because they have the most accessibility to testing. And so we've seen healthcare workers, including RTs, nurses from all specialties. Some of them are requiring it in a hospital, but the bulk of this is still community transmission that's just showing up in healthcare workers. The long-term care snapshot is also very interesting in Ontario because I think this is where the epidemic is starting to settle out and even will settle out in the next few weeks. You can see a significant number of cases in residents, and unfortunately a significant number of deaths in those residents too as well. And it reflects nearly 50% of the deaths we've seen in the province coming from long-term care, as they are a vulnerable population to begin with. This is that modeling data I think we showed. And so looking at confirmed cases post 100th case and deaths post 100th case, and some early but promising signs that the curve is flattening in Ontario, both in terms of cases and in terms of data. You'll see that if you do go through the Ontario report, they report kind of two scenarios. One, the Italy scenario, which all of us know Northern Italy went through a catastrophic exponential growth phase where they overwhelmed healthcare systems. And then the South Korea scenario where they were able to overcome their epidemic without overcoming healthcare systems and had a flattening of the curve, although there's still ongoing transmission there. But again, a controlled transmission rather than an uncontrolled transmission. And then finally, this was the more promising document from the modeling from yesterday. And so you see the purple is actually Ontario ICUs, and the blue being the best case scenario, i.e. the South Korean scenario in terms of modeling of transmission. The green was actually what we thought Ontario was going to be based on modeling data going into this in March. And the pink is actually what Ontario's numbers look like to this date. So we're actually running even better in terms of our ICU capacity based on the South Korean model, and better definitely than our current model. And really, we haven't even touched the upper limits of what we can go through in terms of capacity, in terms of just baseline, not the surge capacity that's being expanded to. So this is promising. It's not over yet. There is some discussion here. You know, that long-term care has really been the hardest hit. And so these patients are probably not represented in ICUs, as many of them have DNR orders, so they would not be ventilated or need ICU stays. And again, there is some geographical differences in this. The situation kind of Hamilton and West is very different than, you know, as you get into Peel, Brampton, and the GTA, where there is a little bit more local surge than anywhere else. Okay, so that's epidemiology. I always throw in a couple of funny slides. Remember to wash your hands. When we talk about transmission, we talk about two major or three major mechanisms for the coronavirus. So one is droplet transmission, where we see these respiratory droplets, the large droplets that are greater than 5 microns. They travel 1 to 2 meters is where that 2 meter length comes from. And so those are either inhaled and colonize the upper airways, or those droplets settle on surfaces, which then are contacted by either mucous membranes or hands that are exposed to mucous membranes, or indirect contact to the individual through a fomite. And then we talk about these airborne nuclei, so these less than 5 millimeter nuclei that travel quite a bit. And so these are the so-called airborne precautions. So I think we have a good sense of droplet precautions, but where a lot of the questions come up is, what is the airborne nature of this disease, and how does it relate to the precautions we need to take for this disease? And so I wanted to first step back and say, sorry, the word airborne is being used differently than the traditional airborne organisms out there. So when we think of traditional airborne organisms, we think of things like tuberculosis, varicella zoster, measles. These are the typical things where everyone wears an N95. Patients are put into airborne negative pressure rooms to then make sure that that airborne transmission on those tiny droplets that are suspended in air is maintained. And these organisms are programmed to live on those surfaces, live on those tiny, tiny respiratory droplets. So tuberculosis is the classic example. TB is a bacteria, the Mycobacterium tuberculosis, with a very, very thick wax layer around it. And so it makes it very, very difficult for the organism to break down with dehydration and the typical things that happen on a respiratory aerosol. And so they're programmed to do it. So TB bacilli are found in environments greater than 2 meters from a patient who's actively coughing, and it's from the lower airways. They infect the lower airways of the recipients, and so that process is very well documented. Varicella and measles follow a similar pattern. They're highly infectious. The viruses are highly stable in the environment on aerosols. Other respiratory viruses like influenza, RSV, rhinovirus, and coronaviruses can become aerosolized under certain conditions. There are probably a very small amount of aerosols that are negligent to actual transmission, that are with the coughs and sneezes. But the concern for these organisms really becomes when you're doing something artificially to someone to generate those aerosols. So in standard conditions with the typical cough, the organism is really only primarily transmitted by respiratory droplets, and only under certain conditions is where that aerosolization becomes a major issue. And so you may be asking, why do we assume this? And it comes from a number of different things. One is we know other organisms in certain studies, even in certain conditions, can actually be aerosolized similarly. So for example, influenza is very well known in certain scenarios like airborne, bronchoscopy or aerosol generating procedures actually can become airborne as part of that. But I think most of you have probably been involved with someone that has influenza that may need respiratory support, positive pressure ventilation, or intubation, and you're walking in with a droplet mask, because we know that in the most case, that's you're not acquiring the virus that way, even though you can certainly find and generate respiratory aerosols in that sense. Rhinovirus is the same. There's actually some interesting ENT studies looking at patients getting surgery on their airways when they're cutting. They're actually aerosolizing MRSA. But again, you are wearing a mask for most surgical procedures, and we don't see our surgeons coming down with MRSA pneumonia. Group A strep is very similar. Even interestingly, C. difficile in certain outbreak settings can be seen in the aerosols. And again, we don't really get much sense that people are actually infected through aerosolization in that sense. So that's number one. You can aerosolize a lot of organisms, but they're mechanistically not that infectious in that sense. Remember, when we talked about the coronavirus, this is an enveloped virus. It has a fatty acid layer. And so it is dependent on things like humidity, temperature, and surface conditions to actually make sure that integrity is stable. The other argument that this is not an aerosol disease outside of aerosol generating procedures is the fact that the reproductive rate is much lower than what would be expected with an aerosol disease. So tuberculosis is about 4, i.e. one person infects 4 other people. That's actually relatively on the low side, but there are some things about tuberculosis where you do need a significant burden of disease to get to the lungs and the lower tract to actually establish it, but much higher than what we're observing in some of the studies, particularly with certain controls in COVID. And then when we talk about measles and varicella, we're talking about 12 to 18 people. So a single person is infecting 18 other people. If you look at the studies in the United States of people as they first started getting coronavirus, they looked at family members of patients that had COVID-19, and there was only a 10% attack rate in those family members. And they then looked at people who were close contact but not family, so friends and other peoples in the household. and 0.5% of those people actually acquired COVID-19. So you're definitely seeing not as many cases generated from a primary case, whereas if you had a household with measles in it where everyone was non-immune, everyone would have measles. It's almost guaranteed that that would be a situation. And then finally, there are a number of PPE studies looking at the use of N95 and droplet precautions for particular situations in influenza and in SARS. The influenza study that was actually generated from my colleague Mark Loeb, who's our division director, also had a subgroup that looked at those human coronaviruses we talked about earlier. And you see that the people who use N95 masks have a similar rate of infection as people that use droplet masks. And again, this is not in aerosol generating procedures. These are in routine care of patients who are coughing and sneezing, etc. So I think we have a good understanding that the viral transmission in regular folks is mainly droplet. And we'll talk about the aerosol generating medical procedures in a couple of slides to go through what that means in terms of some of the provincial guidance. The problem with this is there is a lot of experimental studies being done that are looking at aerosolizing this virus and saying that it is an aerosol disease. So this one actually came out of the New England Journal. It's still, I think it got finally published about a week ago. They used this giant cauldron essentially to aerosolize particles for some time. They used optimal humidity. It was in a lab setting with optimal environment, and then they let things sift onto different materials too as well to see how long they could find virus on there. And so under aerosol conditions, you can certainly aerosolize the virus to let it sit in the air. But those aren't conditions that are natural to humans. One could argue that other than maybe positive pressure ventilation, those conditions aren't even ones that could be replicated in an aerosol generating procedure, maybe bronchoscopy too as well, because these were prolonged aerosolizations of virus. And we'll talk about, in terms of aerosol generating procedures, that duration of actual aerosolization is probably much shorter than a challenge study. The problem is these studies have not explicitly said these differences. And so this study in particular said, there are concerns about infection control. And yes, if we shoved an aerosolizer inside of people's airways and let them aerosolize all over the place, there would be issues for infection control. But from the human model, that's almost impossible to replicate unless you're doing things like positive pressure ventilation. And so this study also looked at things like half-lives on materials too as well, which is probably the more interesting part of things. And they saw half-life in air of about 1 hour, so about 50% of the virus is degraded. On stainless steel, 5.6 hours, and on plastics, 7 hours, and cardboards was a little bit longer. The other part of this is these studies use PCR as their surrogate marker, so they're looking for virus particles. But when you actually take some of these studies and try to look for viral culture, i.e. live virus, they're very, very hard to find. So it's not necessarily a reflection of live virus. They're a reflection of viral particles and dead virus that shed their nucleic acid. And RNA is actually quite sticky in the environment, if you do challenge studies. So again, the typical and routine care of a COVID patient is droplet contact precautions with face shields, so gown that's ideally impermeable, gloves, a mask, which we'll talk about the different types of masks, and face shield and eye protection. It's important that you know how to don and doff it. So no matter what PPE that eventually gets used for your patient, depending on your risk assessment, your aerosol generating procedure, if you wear the PPE appropriately, you are getting the maximal benefit from it. If you're not wearing the PPE appropriately, you're not getting the benefit out of it. And if you don't take the PPE off appropriately, you're increasing your risk of harm and transmission there. And so often people are putting it on for the first time for a COVID patient. And I would really encourage you to just look up, there's tons of YouTube videos. I didn't want to go through one right now to save the time, but just to go through it, memorize those steps in your head, because as much as you're worried about what PPE to use, it's much more worrisome if you take off the PPE inappropriately and contaminate your mucous membranes, where you're going to have more risk of acquiring COVID than wearing the wrong PPE. In terms of masks, we talk about the procedure and surgical masks. These are those typical soft masks. There are 3 levels to these, 1, 2, and 3. The levels really reflect more of some of the stiffness and the splash ratio of those masks. So those are really generated from operating rooms. A level 1 mask is good for kind of day-to-day minor splash procedures. Whereas if you're doing a very bloody procedure like open cardiac surgery, or a vascular surgery where there's going to be a lot of bloodshed, you want a stiffer mask because you don't want that splashing and then splattering on terms of your mask. For the purposes of COVID-19, any procedural or surgical mask fits the definition of a mask to use for routine care. You can see the different ways masks work here. So inertia, interception, diffusion, and electrostatic forces. And so both procedural masks and N95 masks provide this. Procedural masks filter out about 10 to 90% of molecules going in. So there is still some protection for some of those droplets and even some of those aerosols with a procedural mask. They're very dependent on the fit, so make sure they're snug, pinched on the nose, that they're not hanging too high on your chin. And then the N95 mask, as we've all been fitted for, is very dependent on its fit. So a poorly fitted N95 mask is fairly useless. And then again, the term N95 comes with the fact that when in lab studies, when they throw sodium chloride at it, it filters 95% of these challenge particles. So quickly, just talking about reprocessing, because I didn't know anywhere else to mention this. This is something that might be coming down the pipeline. So there's been clear evidence, I think, for all of us that PPE is not overwhelmingly available and sustainable in many settings. Health Canada and Ontario Health have a framework in place for reprocessing. They haven't recommended things as of yet, but have given a strategy to hospitals that are considering it, particularly for N95 masks, because they are the harder to find masks currently with our environment. In terms of mechanisms to consider for reprocessing and to consider recollecting these masks for reprocessing. And the method that's been used quite a bit is hydrogen peroxide-based therapy. These assays are not based on tests on COVID-19 because you need a certain biosafety to actually work with the organism. They use other biologic controls as well as mask integrity controls. And so they're not standard of care yet. We've even internally had our discussions and are recollecting those N95 masks for the particular use. And if we do get to a scenario where we have to do it, we should do it. I think there are obviously some concerns about reprocessing. Remember, if you have an operation done, the odds are that the equipment that you're using in that operation have been sterilized at some point. And so we are very used to using things over again in the medical context. These machines, like the hydrogen peroxide machine, the STERRAD that we're using, are the same machines we use to reprocess equipment that goes into human cavities. So I think we can be relatively reassured that these are relatively good methods for a virus that's not very environmentally stable. But again, these are down the line if we do run out of N95s. I don't know many hospitals that are actually using reprocess supplies now, but there certainly is a lot looking at in terms of recollecting those masks so that if we do need to reprocess, we can reprocess. And there's similar processes being looked at for surgical and procedure masks. These seem to have a better supply right now, so I'm not sure if we'll ever get to that point. Okay, so we're moving on to AGMPs because I think this is probably the biggest concept that people have concerns about. And the province has come up with recommendations around AGMPs from PIDAC, as well as from Ontario Health, although they differ a little bit. And some of them don't make a lot of sense. one of the things, actually, I'll email the cough and sneeze document to the organizers here, because I think it does have a good explanation. But to generalize it a little bit, that discussion we had on aerosols being a generated thing here, but they're not similar to those TB aerosols, those measles aerosols, those varicella aerosols. They're still very localized aerosols. So they're typically around the patient still. Remember that our rooms that we do surgery, that we house people in the ICU, even if they're not negative pressure, there's still some airflow to those rooms, so that those particles are being filtered out at a relatively rapid rate. They're usually short-lived. And so, go through the example of an intubation on a paralyzed patient. You're putting the glide scope in. There's not going to be a ton of coughing. There might be a little bit of suctioning. But if you're using, as most of the recommendations are, either a very elective patient or a very experienced operator, you're not hopefully going to be generating a ton of aerosols. This is a pretty quick procedure that's being done for these patients. And so the amount of aerosols actually generated isn't going to fill the room. This isn't the horrible TB-like or measles-like aerosols we're seeing. You're going to generate a very small amount of localized aerosols as part of this procedure. And that's where these recommendations for people to wear an N95 mask briefly at the intubation. People can be at the other end of the room potentially and wearing a droplet mask, for example, a patient getting surgery where people are working on the airways and the surgeons come in afterwards. Because we know that most of those aerosols are going to be around the patient, that the laminar flow of the room is probably going to take some of those particles away. And so there's really not that much aerosol generation from that procedure. This is also where this concept of vent disconnects came from too as well. So the vent disconnects for a few seconds with a turn or something along those lines. You're not aerosolizing a ton. You reconnect very quickly. Most of the circuits do have filters too as well. And so you're really not generating a huge amount of aerosols, not much than what would be generated with a cough and sneeze, which we don't really think much about anyways. This is different than the other highly aerosol generating procedures. So I'm not going to say that no one needs an N95. There are people who intubate for sure, CPAP, BiPAP, upper airway surgery, high flow oxygen, nebulizers. They all create ongoing aerosol particles. Deep suctioning creates ongoing particles. And so those are still considered bronchoscopy. Those are all still considered aerosol generating procedures. It's just those short-lived procedures, I think there is a real thought about them really not being as infectious as we think. And I'll go through one study that'll help highlight some of that too as well. So here's the current list of AGM that are not AGMPs based on the cough and sneeze document. I'll send that to you though, just to have a good read through, because I think that's important. So you'll see things like vent circuit disconnects, chest compression, where you're really generating a very small amount of PEEP, and so you're not really aerosolizing a ton. Obviously, if you're doing an airway procedure with the chest compressions, that's very different. Gastroscopy, where you're going into the lower GI tract. There's a very tiny risk of intubating the upper airways, but again, you're probably pulling back very quickly that you'll have a very tiny amount of spillage. And some of these other procedures where you're really not doing a ton. Chest physio outside of breast stacking. Breast stacking is very low airway, so theoretically could generate, especially if you're using a device with that. And then oxygen delivered less than or equal to 6 minutes per liter, or less than 15 meters by Venturi masks or non-rebreather masks. So kind of what you can typically do on the wall rather than encouraging these OptiFlow or other devices. It's interesting, there was a preprint article that came out even looking at OptiFlow and the aerosols generated from that, and it looks like it's pretty minimal, but again, we would consider that as an aerosol generating procedure. Quickly looking at intubation, we think most of the risk exists obviously at the person at the front, at the head of the bed. But remember, most intubations are paralyzed, sedated, glide scope, at least the recommendations now for the COVID patients. So not a ton of coughing, there is some aerosolization. This was a really cool image from an article on the intubation box, which is being talked about quite a bit. Looking at a mannequin essentially just aerosolizing during intubation. And you can see most of the droplets still fall on the mask and the face shield. So even some of those aerosols are being caught by the typical stuff that you're wearing, especially if you're wearing a face shield overlying your N95 mask. And so this is where that, thought that even if you are generating aerosols, the regular precautions for things that are very, very short and minimized are probably reasonable. The question that came up is, how long is an airborne room warm for? It's very likely very little time. If you're doing long-term positive pressure ventilation in a room, then yes, it probably does require a little bit more time for those aerosols to clean out, or with a typical N95 room, a couple of minutes. But if there is some sort of airflow, then you're probably even fine. The ministry recommends aerosol generating procedures being done in a negative pressure room, but it's not an absolute requirement. And as long as the doors are closed while you're doing the procedure, it's probably reasonable if you're using the appropriate PPE, like an N95 mask, if you have to nebulize or do a bronchoscopy on a patient. And these are, again, for COVID-19 patients. These are, a lot of the policies have been generated for COVID-19 as the default patients, but these are specifically for COVID-19 patients. So I want to reassure people one other way too as well. And this is a study that came out of Singapore. So this was very early in the disease outbreak, where it was still a very travel-associated disease. Singapore's cases were generally not local transmission. They were still from the Wuhan region. But this is one of their first community-acquired cases. And so this is a middle-aged man. He had typical vascular risk factors. He was admitted for community-acquired pneumonia. At that time, most countries were not considering COVID-19 as part of the differential diagnosis if people had not traveled. This person, at the end of the day, had a contact that had traveled. So he develops hypoxic failure. He's intubated with a glide scope. It apparently was a very difficult intubation. They had to use a bougie as well as part of it. And then he's extubated day 3. He's extubated to BiPAP and continues that for some time. And then once he's sitting there on BiPAP, the clinicians think, this guy sounds like maybe he's this COVID-19 thing. Maybe we should send the tests off. 2 days later, the tests come back positive. So this guy has been intubated for 3 days and has been on negative pressure ventilation for another couple of, the non-invasive ventilation for a couple of days, and aerosolizing a huge amount everywhere. So there were 41 people exposed to these AGMPs for greater than 10 minutes and less than 2 meters, not 2 minutes. They were isolated and sent home, which would be routine practice for us here too as well. They actually swabbed a bunch of them from day 1 to day 14. About 10 people had N95s as part of this. It sounded like it was just kind of pick your own, and the other 31 did not. None of the people that were exposed to the BiPAP had an N95 mask on. And so in the follow-up of these patients, there were no cases of COVID-19, both symptomatic or asymptomatic on swab detected. And so that's at least reassuring that what we do, even as a fail-safe, not that we would let people go out without an N95 for someone on non-invasive ventilation, but the risk even to providers for that is not as high as we think. We obviously try to minimize that risk, but this is just a good principle and practice that we could obviously not replicate for ethical reasons in other sets. Other protections, so head and neck, there may be some splash of droplets and aerosols at the time of intubation. There's no consensus on what to use here. If you're touching the area and you touch your mucous membranes, there theoretically is a risk of contamination. So these neck shields and head shields are being thought of. Some centers are using them standardly. Some of them are using them at discretion of the person. I would say for intubation, it's probably the person at the head of the bed. As you can see that splash picture, that the person at the head of bed probably gets most of the splash and the rest don't. If you do use something, there's a lot of different models, particularly if you're using something, is practice taking it off first before you use it, because again, these things are just as much of a risk if they're taken off improperly rather than being taken off properly. If they're reusable, make sure they're being cleaned regularly and trying not to wear them in areas where there's not COVID, as you're walking around with a COVID infected fomite if you've been in a COVID positive room. And then shoes are the other thing. There's one study out of Singapore looking at someone that was shedding in their room and the shoes were contaminated. It's not really clear how risky shoes are. Again, other pathogens in the hospital are probably picked up by shoes too as well. It depends who you are and who's touching your shoes. They probably do last in the range of hours in ideal humidity, which isn't necessarily what we expose our shoes to on a day-to-day basis. You can consider the surgical booties if you can doff them without contaminating yourself. If you are wearing shoes like me around the hospital, I generally would just leave them outside the door and wash my hands when putting them on and taking them off. And the risk of you're not aerosolizing them when you're manipulating your shoes. It's just touching the shoes and then touching your mucous membranes, which is the issue. I wouldn't necessarily wash my shoes any differently either. This is a little bit of humor before we move on. I'm going to quickly get through the rest of the slides, and I realize I can stay a little bit longer for questions, but I realize I'm running low on question time. One of the big questions that comes up is asymptomatic carriage, and so what is this and how does it look? So these are some of the early models of asymptomatic carriage. The airplane study, which was Air Japan, took people from Wuhan to Japan. 4 of them did develop symptoms after their flight, so they were infectious during their flight. There were no secondary cases of transmission then. The Diamond Princess cruise ship that you heard a lot about, when they swabbed everyone, there were about 46% of patients that actually had no symptoms whatsoever and developed no symptoms whatsoever. There's some modeling studies suggesting that 50 to 60% of the Wuhanese people were undetected, either very minimally symptomatic or asymptomatic. And the viral loads among symptomatic and asymptomatic people don't seem to be terribly different in certain circumstances. We do know there are also transmission chains of asymptomatic carriage when this was, again, much more of a localized infection. So a group of Shanghai travelers that infected a person from Munich and then infected a bunch of locals. There was a Wuhanese traveler that had come to Singapore and infected their family. And again, those people were asymptomatic at the time of their infection. This is just a modeling study out of Wuhan that suggested that 86% of infections were undocumented and about 55% of transmissions were undocumented. I put this up because there's actually some emerging data that came out this week around some of this asymptomatic transmission. So New York, as we talked about, is the epicenter on Earth for coronavirus. And so an interesting study actually showed that 13% of women walking in for delivery without symptoms were COVID positive. But there is some data suggesting that probably 5 to 10% of the population of New York is infected or has been infected. So we're talking millions and millions of people that have acquired the infection already. And then another interesting study that was done in Iceland very recently, where they screened patients that they thought were higher risk, so travel and symptoms. And then they invited people to come get tested if they wanted to get tested for whatever reason they wanted. They got about 10,000 people. 80 were positive, and they looked at symptoms for those 80. And even though they asked for people who were asymptomatic, about 50 to 60% of those patients had symptoms still, usually kind of cold and cough symptoms, but they still had symptoms. They then did another study where they texted 6,000 people and invited whoever wanted to come to get tested. About 2,000 of them decided to get tested. They found 13 people that were positive, who they thought were asymptomatic, but when they went in and again asked them again, only about half of them were actually truly asymptomatic, and a couple were very mildly symptomatic. So whether or not the transmission is actually truly asymptomatic or very mildly symptomatic is the question. And so that does affect our systems in terms of identifying people, as those asymptomatic people might not be tested. But at the end of the day, maybe more of these pre-symptomatic people, particularly in areas where there's not a ton of localized transmission. Pregnancy is one thing I get asked about a lot. There's no definable risk factors for pregnancy. Febrile illnesses in pregnancy in general can lead to preterm delivery. So that's the only concern, but that's the same as getting the cold, influenza, or anything else. There's no concern about congenital infections. There was one case of a baby which had higher than what would be expected antibody levels, but there's a lot of critique about the way they actually did that testing. Otherwise, most of the babies born to mothers that are positive are negative, and in fact, probably a little bit protected from maternal antibodies. At the time of delivery, for women that are positive or it's a routine delivery, we just leave the baby with mom, and mom wears a mask for care, but they can do everything else routinely. And there's a question of whether or not those babies, if they do need an AGMP, if they need BiPAP or something along those lines, whether or not they can get it. It's controversial. By definition, not, but I think most people err on the side of precautions and would consider airborne precautions. But again, this is center and site dependent. For most of the studies, the babies are swabbing negative in this context. Talking about swabs, the gold standard for swabbing is an NPS swab looking for molecular evidence or genome. There's no gold standard to validate that our NPS swabs are working because they are the gold standard. So we don't, getting sensitivity and specificity data is not easy. We use kind of analysis methods. The other point is the viral load in the NPS peaks at day 5 to 7 when people typically present with symptoms. And then after that starts coming down in sensitivity. If people start developing lower respiratory tract complications, the lower respiratory tract becomes a more sensitive setting. So early NPS, so someone with a very short duration of symptoms within about a week, a single NPS swab is probably reasonable for most people. It's always clinical context. If it still fits the definition and you're not completely convinced, then doing a second NPS swab sometimes is encouraged, or keeping those people in precautions. And then as you get into that late period of day 7 to 14, then really a single NPS is 70, 60% sensitive. And you want to, if you're really concerned, it's the right context, use sputum or an ETA if they're intubated to generate that. If you can't get sputum or an ETA, then we often repeat the NPS. And if they're still very suspicious, we treat them as a COVID patient based on clinical. And then that's based on federal and provincial guidance. So again, not everyone with a negative test is negative, but we are picking up most of our cases through positive testing. There's very few that kind of are clinical diagnoses. The other part is we have no clue how these tests perform in people with asymptomatic disease. We think the viral load is similar, but again, by definition, we can only identify asymptomatic people if they're tested in studies. And so we don't know whether or not there are asymptomatics with very low viral loads we're not detecting on our typical testing. Finally, there's been a lot of talk about blood tests. These are being looked at. There's a lot of cross-reactivity with other coronaviruses, so they're not standard of care yet. And then there's some look at oral or throat or nasal samples to actually just let people swab themselves for kind of more of an outpatient look. In terms of clinical presentation, fever, cough, worsening shortness of breath, and myalgias and anosmia and conjunctivitis are also being added to the list. There are GI symptoms too, as well as in early disease, anorexia, nausea, vomiting, and diarrhea. So a lot of non-specific concerns. The last question I think I'll go over is just how long do people shed? So this was a study that was done in Germany of that cohort of people that was actually infected early on. And they actually kept swabbing patients throughout, and they actually tried culturing off their swabs. They saw very high viral loads day 1 to 4 until their peak, usually at the time of symptoms. They could culture it out of throat, NPS, and lung. They weren't able to get stool, urine, and blood. But around day 10, most outpatients didn't have any detectable virus anymore, and their viral load, the amount of virus they detected on NPS swab, was relatively negative. And so I think we're reassured that day 10 to 14 is usually where people become non-infectious from mild kind of outpatient cases. It's very different in hospitalized or critical care patients. The problem is the ministry is requiring 2 negative swabs for a lot of people to return to work, which may not be an ideal measure because that people may have persistence of negative swabs. And so the bottom line is they're probably not very infectious to others. It's just probably some residual dead virus that we're picking up. But for the sake of hospital-based transmission, everyone's being extra careful. It may not be completely evidence-based, and we don't have access to cultures because of the biosafety mechanisms here. I'll leave this slide up on treatment, but I want to really go over questions here. I'll just leave it as there's no guideline-based treatment right now, but certainly I can share these slides in terms of the treatments and the trials that are being looked at right now.
All right,
I am happy
thanks.
to stay an extra 10 minutes too as well. Yeah.
Okay, thank you so much. I just want to say there's some questions already been entered into the question box, so I'll go over a couple quickly. If depending on your time, we might go to like about 3:10, if that's okay. If
Yeah,
we
that's
don't
fine.
get
That's fine.
everything, okay, great. If we don't get everything answered, which we probably won't, because there'll probably be more coming in.
Just give me just give me an email with the rest, then I can try to answer them individually.
Okay, perfect. That's great. Thanks. So there's the first question, and this is actually a good question because I think we all have the same kind of thoughts. So this question is, there's a lot of pressure to wear masks in public, i.e. grocery stores. I live in a low socioeconomic area and I understand and comply. However, as an RT, I feel it sends a confusing message. I worry when this is all over how long it will take for the public to trust their own immune systems. Any thoughts or advice on how to pass that on to people in my town?
Yeah, this cloth mask and the masking in public thing is actually really interesting because it's one of these informational things that got mixed with a lot of misinformation too as well. So it derived a lot from actually the Southeast Asian countries where this actually became a little bit of the culture after SARS. And so as part of their initial response, people were wearing masks in public. And so when people looked back at the data around flattening curves of particular countries, they said, oh, well, these countries in Southeast Asia are wearing masks routinely and their rates of infection in the community are low, therefore the masks must be related to it. As we know, there's probably more than that. It's community tracing, it's access to testing, it's compliance with social distancing and many other factors in that sense. The cloth mask thing got brought up, and you know there was a study back in 2016 that talked about cloth masks and the prevention of respiratory tract infections, both looking at filtration but also looking at people getting influenza or influenza-like illnesses, and they didn't function very well as compared to regular masks. And so the evidence behind cloth masking for prevention of infection is pretty lousy. And so some of the thought then became, well, why don't we use masking as a method to prevent transmission if you're asymptomatically or mildly shedding and you have a mask on your face? It prevents transmission to others if you're wearing a barrier on your face. Even that evidence is not particularly great. So there was a study that was out of South Korea where they actually took people who had active COVID, they slapped masks on their face, and they held a petri dish in front of their face basically to see what would happen, how much virus they would pick up afterwards. And essentially all the masks, the surgical mask as well as the cloth masks, you could still find virus after people had coughed, even with the mask on. So they're not perfect. There is this thought that maybe if you mask up society, you would decrease the burden, and that was initially advertised by the United States, and then the Public Health Agency of Canada essentially adopted it based on the US recommendations. It's not really based on a lot of sound evidence. There's a lot of, well, how much can it hurt? And I think that's the main concept, that people can wear these if they think they're offering a little bit more protection. But the concern is people will throw these masks on and then go out in public and do the things they shouldn't be doing because they think they're extra protected. And so the bottom line is, I think they might offer a minuscule amount of protection. They're not the panacea or the magic bullet to stop community transmission. All the other stuff like social distancing, hand hygiene, respiratory etiquette are probably a hell of a lot more important. But they, people are doing them, and there's federal guidance to consider it. And so even without evidence, this is starting to become a routine thing. But I really have, the only other thing is I really have issues with people using medical grade masks in the community, as obviously we're talking about reprocessing here, and those are available to outpatients. It's not necessarily the best optics for sure.
Okay, good. Yeah, I have the same concern about medical grade masks in the community. You're absolutely right. Okay, next question. Thank you so much. Do you recommend, what's your recommendation for how long after an AGMP procedure is completed one can walk into the room without an N95. So how long are the aerosol particles suspected? I think you touched a bit on this.
Yeah, I think I touched on that. So like a routine intubation, if the door is closed, the patient's intubated, the vent's stable, come in the room. I don't think there's a big deal without an N95 mask, because again, those aerosols with whatever flow is and whatever small amount of aerosols that are generated are probably out of the room at that point, and your typical face shield and mask are probably protecting you against the other small percentage of them. You're probably as at risk of someone sneezing in your face as that is. I think you might want to wait a little bit longer in someone that's getting a big CPAP load and has been aerosolizing all night. You might, if you go into the room, you probably want to at least wait 5 or 10 minutes to go into the room after you take the CPAP off before you kind of go back in routine precautions or droplet precautions. But again, for the typical intubation or the short airway procedure, it's probably very minimal time.
Great, thanks. So our next question, there seems to be some disparity regarding when or if to intubate. Is there any updated data regarding best practice or recommended protocols?
There isn't the Critical Care Society and the Surviving Sepsis Guidelines really recommend for patients that are struggling and going into acute hypoxic respiratory failure, the bridge being maybe high flow oxygen in an N95 and airborne in, isolation room. But outside of that, considering early intubation and not considering negative pressure, non-invasive ventilation. And so yeah, there's not a slam dunk time to say we should intubate. But those patients that are struggling where we would normally do things like slap BiPAP on them and see what happens are probably the ones that you want to intubate earlier rather than later. That being said, there's a lot of discussion, and again, there's not really any evidence that's come out of it where the Italian experience has been saying, well, you guys are intubating far too much and these patients could probably be rode out without any type of positive pressure ventilation. So again, that's being investigated. I think there's a group in Toronto doing a big meta-analysis around this, so hopefully that'll be updated at some point.
Okay, thanks. Okay, our next question is, would home CPAP BiPAP, actually this comes up quite often, we get this question. Would home CPAP BiPAP orientation where the patient is not attached to the positive airway pressure device be considered an AGMP?
So if it's just like, so these sessions are just, they're putting the mask on them, they're fitting, and they're not actually putting any PEEP in them though.
Right.
Yeah, so they would be the similar as someone wearing a mask as anything else. It would be droplet based more than anything else. It's when you start introducing the positive pressure that it becomes an aerosol generating procedure.
Okay, well, that's helpful, thank you. The next question is, what do you think about reusing the same face shield between COVID and non-COVID patients with cleaning with cavi wipes in between patients?
Yeah, I don't have big hindrances in this. I think it's interesting because the face shields are probably the one part of the PPE that will be solved with local ingenuity and innovation, as there's a lot of people with 3D printers that are doing stuff, and they're probably medical grade in the way they act as long as they stay on the face and they're made of an impermeable material. But I think if you're using a very high sensitivity, like a cavi wipe or a peroxide wipe or something like that, you're using it appropriately, you're giving that 2 minutes or whatever the time is for those to work, and you let it dry out, that should be fine. Just make sure that you're wiping it down aggressively. Remember, the risk is not necessarily to patients unless you're shoving the mask into their face or onto their environment. The risk is really to you more than anything else. So it's up to you to actually wipe down those masks aggressively. But I think if you wipe them aggressively and you get every nook and cranny and you let the product do what it needs to do, then they're very low risk to others. And again, you're washing your hands when you're donning and doffing them. Nope. Any other Did I lose you
Sorry,
guys?
yes,
Or?
yes, sorry. There's
Yeah.
another question, one more. What are your thoughts regarding, as we move forward, how long will we be seeing this virus in the community? Is it too soon to tell? Are you concerned with how the US is handling the virus and removing social distancing protocols too soon?
Yeah, it's a good question. There's a lot of hope that summertime brings an end to this infection, but realistically, you see spread in Florida, you see spread areas of the world that are 20 to 30 degrees in Australia. And so I don't think that the summertime per se is going to be a massive change in what's going to happen with the ecology of this. The thing that protects us in the summertime from respiratory infections is that we actually socially distance a bit more. We are outdoors a bit more. We travel a bit more. We're not stuck in close contact settings like malls or meeting rooms or that type of thing. So yeah, we're probably going to see transmission of this for some time. I think we recognize where the transmission is going to be hitting the hardest, particularly in long-term care facilities. But I think our next strategy as we move into the next phase of this infection is mitigating those risks, making sure people are identified who have the virus, who have access to testing, making sure PPE is available for anyone being cared for. But I think we're going to be seeing COVID patients for the future, and it's not going to be until a vaccine or some sort of therapeutic intervention comes into place where the mortality of COVID-19 goes down significantly that we're going to be stopping worrying about this.
All right, great, thanks. Okay, one more question. Is it safe to reuse the same N95 with multiple different COVID patients if covered with a regular surgical mask, since they're all COVID positive anyway?
Yeah, so if you're the safety is fine. Again, we use the surgical mask to cover up. That's fine. And similarly, there's protocols for using PAPRs over a game in a multiple use ward. You see that those images on the news in terms of the Italy and stuff where people are dressed from head to toe providing care. The issue is when you're leaving that care area, that mask has to come off at that point. So if you're going to be in a care area where you're going to be caring for 5 to 10 COVID patients, that's fine. The mask doesn't aerosolize. It's just if you're contacting an environment outside of those COVID rooms, then you have the potential for COVID droplets on your mask to then be contacted to another environment. But I think if you're providing care for 5 COVID patients back to back, you can wear the mask through it. It's just, and probably better from a PPE prevention standpoint that you do kind of the workflow like that.
Excellent, thanks. Okay, this is our last question because we do have to get
Okay.
going. Okay, actually, this has been quite a contentious question and in our profession, and I don't see it ever being addressed in any of the documents. So I'm going to ask you this question. So pulmonary function testing has been included as a AGMP. When PFT labs open in the future, what PPE would you recommend? The test is often 40 to 50 minutes long with the patient coughing, and how would you recommend wiping down the body box?
Yeah, it's a good question. So, I think we have to figure out what the symptom screening is going to pick up the most of the patients. This isn't just an area for respiratory physiology. There's going to be other issues for other outpatient procedures where we're dealing with this. So if someone is certainly in an area where they are COVID or suspected to be COVID, and you're within that 2 meters of direct contact with them for the respiratory physiology testing, like most spirometry, then it would be an N95 as part of it. If it's someone that's really negative for COVID or doesn't have symptoms, then it's probably a no in terms of that. But we have to come up with some other processes to make sure that that's taken care of, like perhaps using a plexiglass shield or something like that in terms of administering the test. In terms of the wipe down of the machines, they're relatively similar. I actually don't know the answer of the actual like spirometry machine in terms of the actual cleaning of it in this context. And the body box, if you're generating aerosols, it's similar to anything else. You could probably, as the door is closed, you know, let the person generate their aerosols, which isn't going to be a huge amount for the time. Open the door after the aerosols are generated. Most of it is going to settle to the ground for the most part, and then, you know, typical cleaning and just waiting a little bit of time before patients are through that. But I actually don't know the complete answer to that. That's a good question. I don't know the complete answer to what's going to happen when respiratory physiology labs open up.
And that's actually a good piece of advice. I think labs, both private and in hospitals, will have to maybe look at the timing of their tests and their patients.
Yeah.
You know, typically we have a fairly quick turnover, but there may be, I think, some lessons learned around, you know, waiting that extra 5 minutes between patients so that you can wipe things down, let them dry, and make sure that there's
yeah, and I think games and other processes in place to minimize that actual direct physical exposure to the patients. I know it's hard when you're holding the spirometer, but yeah, there's probably some mechanisms and innovation that can be said to that for sure.
And I think, and again, you know, I think there's also potential to unfortunately have maybe N95s for those doing spirometry, because you're always really close, like you're within like a foot of the patient, and you can't put a plexiglass thing in between, unfortunately, with those kinds of testing.
Yeah.
But yeah, that's something I think we need to think about for sure. So okay, so we're gonna wrap up. It's almost 4:15. Thank you so much, Zain.
No worries.
That was fantastic. If there's any further questions, I'll send them to you, but I've kind of captured all the answers. We may actually ask you back in the future. This was very helpful. Very helpful.
Yeah. No, I'm happy to.
Okay, great. So just a quick wrap up. Thank you to everybody. I think Kelly might want to talk. We want to say thanks for everybody who joined us. Thank you to all of you who do what you do and help support our organization and our profession across the province. And I've included some handouts in the handout section, and we will likely be sending you a short 3-question survey. So if you get an email from us, please try to take 2 minutes to answer the questions. We do have another webinar on Thursday this week around the use of repurposing anesthesia machines for ICU vents. And Rob Bryan will be talking about that as well. And Kelly, did you want to say something?
No, I just wanted to say thank you to Zain, or Dr. Chagla, sorry, for giving us this great talk today.
Fine, Zain.
And absolutely, anybody has any ideas or anything that's outstanding, let us know, because we can find the people or do our best to make sure that we get the topics covered. So thank you for all that you do. Have a good day.
And the recording will be up on the website in about 2 days. Thanks, everybody. Bye-bye.
Take care. Bye.